First of all, welcome to everyone here. This is our session on public health and specifically the Every Mind Matters campaign. My name is Paul McCrone. I'm a health economist from the University of Greenwich and part of the policy research unit, and I've been working on this with my colleagues who will be presenting today as well. So we've got 5 presentations to start with, and then after the break we'll probably have quite a short break and then have the panel discussion. So it'll be great to be thinking of questions to ask during that. But as I say, our first presenter hasn't managed to get in. I'm keeping an eye on who's trying to join, and so Karen Pinder, who is the head of marketing for mental health in the Office for Health Improvement and Disparities, part of the Department of Health and Social Care, was due to give this presentation. So she sent us the slides, so I think it's okay for us to show these. We won't go through them in great detail. We don't know really the particulars of the content, but let's show these and then we'll move on to the rest of our presentations. So policy context. So the Every Mind Matters campaign is a large national mental health literacy and self-care program. It's been in development over a number of years and has rolled out, so from 2017 and through to 2021. And obviously the whole campaign was impacted by COVID. So that's probably affected a lot of what we'll talk about later. And you can see there at the bottom, the campaign focuses on Public Health England's objectives for public mental health. So looking at parity of esteem, looking at risk factors for mental health problems, thinking about prevention, and looking at sort of wider systemic issues as well. So the programme funding was for 3 years, from late 2017 through to 2021. And was rolled out in a number of phases, and the campaign evaluation that we're going to be talking about began mid-2018 and then through to 2021. So I'm not going to go through all of this. It's very small font, but it's looking at the general landscapes, so thinking about prevention and maintenance, looking at different conditions, symptoms associated with conditions, a large focus on stigma and discrimination and signposting as well. And a lot of this builds very much on the previous Time to Change campaign as well. So it's a sort of a sequential approach to developing public mental health campaigns. So overall objectives. So trying to equip adults to take action to protect and improve their mental well-being, a large focus on mental health knowledge, mental health literacy as well. So the short-term aims of the programme, so increasing knowledge, confidence, motivation, a quite detailed website was developed and people were invited to access that. And ultimately, longer term aims are trying to improve mental health literacy and hopefully through that mental health outcomes as well, helping people to access appropriate support, reducing stigma and discrimination. Core audience on this slide. So well, I think it's, from my knowledge, and feel free to anyone to chip in as well. So it's helping to support people who would consider they do have mental health particular needs, challenges, but general awareness in the community as well, and trying to prevent problems starting in the first place. So in terms of evaluation, I think it was initially rolled out in the West Midlands, wasn't it? There was an initial pilot in the West Midlands and then a national rollout. So, well, East and West Midlands. So testing of the digital content with a sample of 1,500 people, TV advertising campaigns, radio advertising as well, various social media users, and then a large multimedia advertising campaign across the whole of England, and lots of publicity given to the programme. So there's the website, the Every Mind Matters website, which is very useful, which includes information about particular conditions, well-being, challenges people might face going through life, what may impact their mental health, their well-being, support for others, and then signposting for urgent support, and that can be provided. And there's this is the Mind Plan, which can be accessed through various technologies. So asking people how their mood is, issues about sleep, anxiety, stress, worry, so things that will affect us all. So it's trying to take a very community-focused approach. Email program as well, linked to the Mind Plan. And then various promotional campaigns have been developed by the DHSC, so Twitter campaigns, mass media campaigns, and yes, lots of celebs getting involved in it as well. Affected by COVID, but then recognizing that particular issues would emerge through COVID as well, that the campaign needed to address. And so I think this is the same as earlier slides, isn't it? So you've got the short-term and long-term aims and of the campaign, but then linked to that's obviously linked to the evaluation that's been conducted as well. And so impact, what's been found out so far, and we're going to touch on this ourselves to some extent. So there's strong results being delivered. So reporting behavioural change, digital actions, and so you've got some key performance indicators, for want of a better word, using the jargon. So 2 out of 3 of those who complete the Mind Map email program report better mental health from when they started. 4 out of 5 completers of either program agree that they're now looking after their mental health a key part of their lives, and 4 in 5 program completers agree that they've seen a positive change in the way they feel when using advice from Every Mind Matters, from the Mind Plan emails. Thank you. Bit of a whistle stop roll. I probably won't take questions on that. So what I'm going to do now is hand over. So the research team who have been conducting the evaluation are going to do presentations now. So I'm going to start off with Ruth Stewart, who's a researcher with the Mental Health Policy Research Unit based at King's College London. Worked with Ruth for many years now. So over to you, Ruth. So you're going to start off. Do you want to sit there? You can operate it.
So as Paul said, I'm one of the mental health research team who've been evaluating Every Mind Matters. And this is our presentation of the qualitative aspect of the evaluation. For this presentation and the ones that follow, we have to say that our views are not those of our funder. This is the qualitative interview studies was published in February. It was in more detail than I can give here, but you can see the names of my co-authors there. So the Policy Research Unit has a lived experience working group who contributed to the design of the qualitative study, and 3 researchers from the group had a big input, conducting interviews, working on the analysis and writing the paper. And then 2 members of the working group wrote a commentary on the paper, which was published along with the study. The study was limited to 20 interviews. Public Health England, who are the originators of Every Mind Matters, placed a form on the Every Mind Matters website for people to leave their contact details. But the Lived Experience Working Group suggested that we purposefully recruit a second sample of people, specifically with mental health conditions that the Every Mind Matters campaign didn't cover. We sent out demographic questions during the recruitment stage, and actually it wasn't difficult to get a diverse sample, although we did have to extend recruitment in order to try and make dates for interviews with more men. Public Health England were keen for Every Mind Matters to reach particular groups of people who are more at risk of mental health problems. So as part of our demographic questions, we simply ask people to tick whichever, if any, groups applied to them. And you'll see from the numbers that all the boxes were ticked by our sample of 20. We also asked people about if they had a mental health diagnosis. 14 of our 20 reported one or more diagnoses. So more than double the number that we purposefully recruited. The interviews were conducted in a period between Every Mind Matters campaigns. So none of our, or few of our participants would have had much exposure to the campaigning at the time of the interview. We needed 2 topic guides because of our 2 samples. With sample 2, we didn't presume that they had visited the Every Mind Matters website. But actually it turned out everybody had. And although 4 of our participants were carers, all but 1 person was looking at Every Mind Matters for a problem for themselves, a current problem. Although for most people, it was a problem they'd been dealing with for a long time. 12 of our participants recorded that they had past trauma. Some had chronic physical health conditions, sleep and stress problems, and several were affected by the pandemic, either as frontline workers because they were on furlough or made redundant, or because they were having to self-isolate while living alone. The team identified 4 themes. And for the first theme, I've only got 1 slide because there was such unanimity about the presentation of Every Mind Matters. Everyone found it attractive and friendly. Even a participant who was unwell, he talked about having a foggy brain at the time that they were looking at Every Mind Matters. But even they said, oh, it was easy on the eyes. And everyone liked the mix of short chunks of text, photographs, illustrations. They liked the layout and they found the navigation easy. And the only criticisms really were about the tone of the text that was aimed at young people. And also, one participant wanted to say she didn't like the assumption that it was abnormal to be worried or anxious. You'll see from the slide, sample 2 participants have a 2 in front of them, sample 1 have a 1. So the second theme about it being a personal experience, this is the Mind Plan quiz with its 5 questions about mood, sleep, anxiety, stress, and worry. All but 1 participant tried the quiz, and it's what people talked about most in the interviews. The quiz generates a personalized plan, and for example, 1 participant who was feeling overwhelmed said this plan gave them a focus. Or for other people, the suggestions in the plan weren't new, but they still found it beneficial. because it endorsed things that they had learnt for themselves over the years. The recommendations in the plan could be swapped if they were unsuitable, and you could save the plan by asking for it to be emailed. And then Every Mind Matters had your email address and they would send follow-up emails or reminders. And our participants really liked this. 2 participants wanted to be interviewed because they were so grateful to Every Mind Matters. And those 2 had both used the same 2 suggestions: relax your muscles and mind, and reframing unhelpful thoughts. And then we had another participant who was a clear example of it working for mental health literacy. The participant who'd looked at Every Mind Matters the most, twice a week for 6 months, had in that time been able to identify their problems and decided they needed help. So at the time we interviewed them, they talked for the first time to their manager at work. They'd been signed off work and they were waiting for therapy to start. The third theme is about context. The participants wanted Every Mind Matters to acknowledge the context at different levels. So the personal context, that mental health problems just make life more difficult. For instance, 2 of our participants weren't able to complete that 5-question mind plan quiz. And also people wanted Every Mind Matters to acknowledge that they might have already tried and still feel distressed, or that people can relapse. Then there's context at a social level. Some participants describe difficulties trying to get privacy in order to carry out the recommendations. And even though Every Mind Matters addressed the pandemic, participants thought they didn't acknowledge the wider social context. And one participant said that in the mind plan question, what's been worrying you over the past 2 weeks, some of the optional answers should have been the climate catastrophe or the government. And then there's the context of the health system, and several participants talked about the urgent help page that Every Mind Matters offered, and which signposts people to 999, mental health crisis services, or third sector helplines. And we had one participant brought up the concern about public health campaigns generally, that they had years earlier, a healthy eating campaign had detrimentally impacted them as a young person with an eating disorder. So they had a concern that public health campaigns have unintended consequences. The final theme is more. Some sample 2 participants were disappointed with Every Mind Matters, but they didn't want it to discontinue, and they had constructive suggestions for it. There were suggestions from both samples. People wanted more choice, sort of different styles of offering. The illustrated breathing exercise is very abstract, which someone really liked, but someone else who lived in a noisy environment wanted things like that to be more immersive with sound and photographs. People wanted more interactivity, for example, being able to log what they were doing and log their improvement. And people wanted more information, for example, the types of therapy on offer, what they do, where they can be accessed, who might be eligible for them. And participants in sample 2 wanted Every Mind Matters to be more inclusive by covering the conditions that they were experiencing. So we have 4 conclusions. Every Mind Matters should build on its success. And 2, that Every Mind Matters cannot select its audience. People with long-term and severe mental health conditions are looking at the website. So they could offer more stratified advice, or at least include a disclaimer. For example, if you're already under the care of your local mental health team, consider contacting them. 3, Every Mind Matters isn't separate from the health system. It doesn't help to signpost people to services that are already overwhelmed. And finally, unless Every Mind Matters can become more inclusive, people may have existing experiences of exclusion and unmet needs compounded. Thank you. This is the names of the research team there.
Thanks, Ruth. And we're going to move swiftly on to Chong. So Kia Chong Chua, who is a senior lecturer at King's College London in applied health statistics, and has been working on this evaluation as well. So Chong, over to you.
Sorry, small tech difficulties. Just trying to get it on the right screen. Yeah, I just needs to come onto the screen for me.
Hi, thank you, Paul, for the introduction. So the funder statement for the previous talk applies here as well. So in this session, I will focus on some measurement issues in the evaluation of Every Mind Matters. For a quick recap, Every Mind Matters is an online resource that offers personalized recommendations on daily life matters like worries and anxiety, sleep problems and insomnia, stress, low mood, and depression. So each of this is an integral part of mental health literacy, because they are about understanding what mental health is, how we can improve it, and what we should do if we have mental health problems. So on this basis, we went into the literature in search of mental health literacy measures. And we found that the most commonly used definition states that mental health literacy is knowledge and beliefs about mental disorders, which aid their recognition, management, or prevention. Now, if you pause for a moment, do you see any important difference between these two definitions? At first, we did not think there was any, but as we looked at more and more mental health literacy measures, something became apparent. So, for instance, this is a vignette of a mental disorder to test if we can tell that someone has depression. This is a vignette of another mental disorder to test if we can tell that someone is experiencing symptoms of schizophrenia. Here is another measure that tests our knowledge of in mental disorders like social phobia and generalized anxiety disorder. And a last example of another measure that focuses on symptoms of mental disorders to test our mental health literacy. So in general, the predominant focus across mental health literacy measures is knowledge in signs and symptoms of mental disorders. But if we devote some time every day to read the Bible for psychiatric diagnosis, the DSM, we may gain more knowledge in mental disorder symptoms. But does it mean that we also know how to better maintain or protect our mental health in daily life because of this knowledge? In other words, is literacy about mental disorders the same thing as mental health literacy, Does knowing more about mental disorders help maintain or protect our mental health? The concept of mental health literacy has actually evolved and expanded in the last 20 years to focus beyond mental disorders. But as you saw, the mental health literacy measures have not evolved much beyond this focus. So against this background, we made a case for developing new measures, even though there are already many out there. With a focus on mental health literacy in daily life, we argue that not only does it has broader relevance for the general population, but also for people with lived experience of mental disorders. So for evaluating Every Mind Matters, we did not test knowledge in mental disorders. Instead, we test whether people know or people can recognize changes in daily behavioral patterns when mental health is affected, and whether they know the daily life actions that protect or maintain mental health. Besides knowledge, we also looked at attitudes. Typically, mental health literacy research focuses on attitudes around stigma and help seeking. But stigma is something that can be affected by social desirability in self-reports, and help-seeking attitudes may differ between people in different places because of access to healthcare. We focus instead on attitudes that are less affected by these factors, and that is vigilance around one's own mental health. So this is the knowledge measure that tests if people can recognize changes in daily behavioral patterns when mental health is affected. It has 3 identical sets of 9 items for stress, anxiety, and depression, respectively. This is the second knowledge measure that tests if people know the actions to take for maintaining mental health in daily life. It has 3 identical sets of 7 items for stress, anxiety, and depression. The third measure is a single set of 12 items that looked at attitudes around the need to be vigilant about our own mental health in daily life. So as the pandemic has taught us, what is highly prevalent is also highly relevant in our daily life. So observational studies in the pandemic showed that at least 1 in 5 experiences stress, anxiety, and depression. So our focus on these issues as such would be relevant to people in general, whether or not they have lived experience of mental disorders. Now, we may have good reasons for developing new measures, but this does not guarantee that we will develop good measures. So in the final few minutes, I will talk about internal and external integrity of our mental health literacy measures. This essentially is about whether our measures do what it says on the tin. For internal integrity, we need to know if the items we develop can work as a team. This means when people get a low score on an item, we expect them to also get a low score on the other items. Like looking at 10 thermometers, if they're going in different directions at the same time, we know that they are not working as a team. This also means they are not measuring the same thing. Without going into the statistics, our structural validation analysis tell us that the items we develop do work as a team. For external integrity, we check if people get a high score for mental health literacy, do they also get a high score for knowledge in sleep hygiene and a low score for stigma around mental health. It would be weird if they have high mental health literacy, but little knowledge in sleep hygiene or a lot of stigma around mental health. In other words, external integrity is about how our measurements are corroborated by other things that should be related to mental health literacy. Using the thermometer analogy again, when the temperature rises for our mental health literacy measure, we see that the temperature also rises for knowledge in sleep hygiene. Stigma actually goes in the opposite direction, but here we just flipped it around. As you can see, the corroboration is far from perfect, but this is okay because they are not measuring exactly the same thing. What we need is consistency across these measures to conclude that there is evidence of external integrity in our mental health literacy measure. So this is also the case for our second measure of knowledge and for our measure of attitudes in mental health literacy. Finally, we also looked at external integrity by testing if people do score higher on mental health literacy, if they have some personal experience of mental health conditions. So we found that people have more literacy for recognizing daily behavioral changes if they have lived experience of mental disorder, a mental health condition, or seen a doctor for mental health concerns, or known someone close with a mental health condition, or worked in mental health care. These logical group differences were also largely found for literacy in daily life actions and vigilance around mental health. Our expectations of these group differences were also partially corroborated by knowledge in sleep hygiene and stigma around mental health. Overall, we show that our concept of mental health literacy can be useful, even though we shift to focus away from mental disorders. But our findings still need to be replicated, particularly in adolescents, because most mental health difficulties begin in youth. Also, there are still many other aspects of external integrity that we need to investigate. And finally, we need studies that make direct comparisons between our mental health literacy measures and those that focus on mental disorders. Thank you.
Very strong and absolutely perfect timing as well. It's the second. So, well done. So thanks very much. We're now going to hear from Jane Hahn. Jane's a researcher with the Policy Research Unit as well, and also a PhD student, I think, at UCL. So Jane, over to you.
Okay, can everyone hear me all right? Let me just move this closer. Okay, hi everyone. Today I'll be presenting our findings on the changes of mental health literacy outcomes in the general population over 30 months and the associations between campaign awareness and mental health literacy outcomes. I'm going to go through the introduction first, then explain to you how we've done this and what the implications of our findings are, but I want to reflect the statement that the current statements I'm about to make in this presentation isn't the opinions of our funders. Okay. So 1 out of 6 people between the ages of 16 and 65 experience a common mental health disorder, but only 1 out of 3 of these people receive mental health treatment for their common mental health problems. And Every Mind Matters attempts to fill this gap as the first national mental health literacy and self-care program by promoting mental health literacy within the population, by promoting good mental health and well-being, understanding mental health problems and their treatments, reducing stigma, discriminations, and barriers to seek help, and enhancing help seeking and efficacy. So with these long-term objectives in mind, we have to ask the question, how effective is the Every Mind Matters platform in increasing mental health literacy in the general population? And in order to answer this question, we have 2 objectives. The first one is to examine changes in mental health literacy outcomes in the general population in England from September 2019 to March 2022. And the second objective is to compare these outcomes between those who are aware of the campaign versus those who are not aware of the campaign. So how did we do this? For our study, we used a repeated cross-sectional sample using different respondents from each survey wave. There were 9 survey waves over 30 months, with the baseline survey wave happening in September 2019 prior to the campaign launch, and then 8 subsequent survey waves thereafter. We used quota sampling via a market research panel maintained by YouGov, and this was to ensure that our samples would be generally representative of the demographic characteristics of England. In terms of our outcomes, we looked at various outcomes in line with Kutsher's definition of mental health literacy. And those things included symptom recognition and management for depression, stress, and anxiety, mental health vigilance, sleep literacy, help seeking self-efficacy, psychological well-being, self-efficacy, and stigma, which expresses a desire for social distance from those with mental health problems. And the higher the score, the higher the desire for social distance, or the lower the desire for social distance, excuse me. In terms of our exposure, we looked at change over time. We compared 8 survey waves from October 2019 to March 2022 to the baseline survey wave prior to the launch of the campaign in September 2019. And for campaign awareness, we asked respondents if they remembered seeing this ad recently, and they were given prompting resources like the one that you see on the screen right now, and they indicated that they were either aware of the campaign or unaware of the campaign. And this question was not asked in survey waves from September 2019, September 2021, and March 2022. In terms of our data analysis for the first objective, when we were looking at change over time, we used a multiple linear regression model where we looked at the mental health literacy outcomes of 9 survey waves and adjusting for things like age, sex, ethnicity, and socioeconomic status. And for the campaign awareness, we used something called an independent patient data meta-analysis. And this type of meta-analysis is generally used to compare effect sizes from different studies. But the reason why we used it for our study is because respondents in each wave were cross-sectional samples of the population, not a cohort. So over time, these samples would have experienced cumulative exposure to the campaign. Further, measurement of campaign awareness differed for each wave due to shifts in campaign initiatives. So we treated each individual survey wave as separate trials and looked at the aggregated effect size across all the different samples. So what did we find? Out of 21,000 total respondents over 9 waves, we selected those with complete data, so data on ethnicities, and this was about 20,000 that we used for our first objective. And then we had 13,000 participants with data on campaign awareness, which we used for our second objective. And if we look at the demographic characteristics for the sample from the first objective, we can see that the sample generally reflects the demographic characteristics of adults living in private households in England in terms of sex, ethnicity, age, and socioeconomic status. And now I'll just go through what we found for our first objective. In front of you, you see 2 graphs, one for symptom recognition and one for symptom management. The y-axis represents the difference of scores from the baseline, and the x-axis represents the time period that we made these observations. The 3 lines represent symptom recognition or management for stress, depression, and anxiety. So for symptom recognition, we actually don't see much of a change in the first 6 months of the campaign, but after March 2020, we see a decline in all 3 scores. And for symptom management, we actually see an improvement of symptom management for anxiety and depression. But once again, these scores either fall similar to baseline, like symptom management for anxiety, or below the baseline level. So the levels either become the same or lower than prior to the campaign launch. We see similar trends with mental health vigilance and sleep literacy, where both measures actually improve over the first 6 months. And then after the first 6 months, mental health vigilance scores decline below pre-campaign levels. And for sleep literacy, they become around the same as pre-campaign levels. And similar for help-seeking self-efficacy and psychological well-being self-efficacy, where help-seeking self-efficacy is similar in the first 6 months, but then decline over the time period. And for psychological well-being self-efficacy, there is an actual market improvement, but these scores decline over time as well. And for stigma, the scores remain similar in the first 6 months, but then continue to decline until March 2022. Our findings for campaign awareness are slightly more positive. We actually find that those who are aware of the campaign generally have higher scores for symptom management for depression and anxiety. And we find similar results for help-seeking self-efficacy, mental health vigilance, and stigma related to mental disorders. So generally, those who are campaign aware have better mental health literacy outcomes than those who are not aware. So what does this all mean? Just to summarize my findings, there was a short-lived improvement in some mental health literacy outcomes that were not sustained beyond March 2020. And those who are aware of the campaign generally tend to have better mental health literacy. But just to go through some limitations, our design doesn't allow to assess cause and effect relationships between the campaign and mental health literacy outcomes. There's also a lack of variables directly related to the use of digital resources. Quota sampling does not provide a generalizable sample, and we can't assess campaign impact of those who do not have digital access. But how do we make sense of these results, given that a significant portion of campaign activity overlaps with the COVID-19 lockdown? And one explanation is that the pandemic may have normalized symptoms of common mental health problems or restricted access to activities that people would engage in to promote their own mental health well-being. But this general decline in health literacy is seen in other populations such as Japan after the pandemic. That being said, we probably shouldn't expect a sudden and large change in effect size with public mental health campaigns over 30 months. Similar in another context, Time to Change, which is an anti-stigma campaign, saw change over a period of 10 years. And the emphasis of Public Health England on helpful behaviors in relation to one's own health mirrors this approach, with both strategies being guided by audience research. Thank you so much. And if you have any questions, please feel free to email me or contact me on Twitter. Great.
Okay, so thanks everyone for coming back, and thanks to all those who are online. We're going to have our panel discussion now. We've been trying to get Karen. We can't get Karen. There's been some technical issues, so she may join as we're going through. So we'll keep an eye on things. So we've got till 4:15 if we need it, and feel free to think of questions. And those online, feel free to post any questions in the chat, and we'll be monitoring that. So I'll introduce the panel. So the speakers are on the panel as well. So we've got Chong again, and we've also got Rachel Rowan Olive, who's a member of the Policy Research Unit Lived Experience Working Group. And Rachel's also an illustrator and a writer, and I looked at her website and there's all sorts of amazing things. So thanks, Rachel. You've been busy today. I know that. And thanks, Jane, as well. And we've got Ruth as well on the panel. So I'll start. Oh, Karen has joined. Hello, Karen. Can you hear us? Are you there, Karen?
I think she's our imaginary friend.
Hi. Yes.
Hi,
apologies.
Karen. Hi.
Hi. Yes, I am
Hello.
here.
Welcome.
Apologies. Hi. Thank you.
Hello.
Yes, tech has let us down on this occasion.
It did. So this is Paul McCrone. I'm chairing it, Karen.
Hi, Paul.
The panel's going. We did go through your slides. I hope I did justice to them.
I'm sure you did. I hope they make sense.
So we've got the we're going to have the discussion now till about 4:15. So I've got an overall question and a series of individual questions. Maybe I'll start off with the individual questions actually, and then we go on to the general question later, or if people in the audience or online have questions. So I'll start with you, Chong. What in terms of the work that you've done, what would you consider to be further work that's needed on measuring mental health literacy? You went into a lot of the details about how we do it. I mean, where's this go now? What's the next steps in measuring mental health literacy as part of public health campaigns like this or other work?
Well, I guess something I alluded to at the end of the presentation as well, really, is to compare our mental health literacy measures with, to make direct comparisons with measures that focus on mental disorders, really, because having looked at many existing measures, we found that actually ours is really the only one that focus not on mental disorders in terms when we approach the topic of mental health literacy. So, but because our measures are the only ones, we really need to address the query that does it really work? We found, I mean, what I presented was preliminary evidence or tentative findings that supports that its usability, its utility for a population health survey. But what would be a more convincing demonstration is a direct comparisons with those measures that actually focus on mental disorders. So that would be something that we'll be very curious about.
Great, thanks, Chong. And I guess continuing on that theme, I'd like to ask Jane a question relating to the mental health literacy results. I mean, how would you interpret the high usage of the Every Mind Matters mind plan versus the declining mental health literacy scores? It's quite diverse findings, weren't they?
Well, I want to reiterate what I've said in my slides in terms of COVID overlapping with a very significant portion of campaign activity. If we take that into account, then I think both findings can coexist. As I said earlier, general health literacy seems to be declining in other populations as well, post-pandemic. And in terms of what we find here in England, I think that the usage of the Every Mind Matters mind plans reflects a demand and a need for these types of interventions under very difficult life circumstances. So it could be that people are trying to look for different ways than they knew previously how to promote their own mental health, and it to a certain degree reflects the importance and the necessity of these interventions for the general population.
Thanks, Jane. And that's really helpful. So I mean, obviously it's quite a sort of technical nature to the evaluation in developing the measures, using these measures, exploring them. So it's good to get your thoughts on that and looking at how that may go forward. I mean, I guess we'll turn to Rachel and Karen, looking at sort of some of the overall issues in a moment. But I'll just ask Ruth, I mean, in terms of the qualitative work that you did, Ruth, I mean, what would you, I guess, what was the most standout finding for you from the qualitative work, and was there anything that was really surprising that came through that?
After I've written the paper, afterwards, I have been struck about that it was easy for us to get a diverse sample of participants. In a lot of our studies, we struggle with that, but there's something about Every Mind Matters that people of all ages and all ethnicities, and young and old, and right across the country, it is connecting with more people than perhaps other services are.
Yeah.
And something I'm quite pleased with the study was we had someone in their 90s, one participant, someone else in their 80s. So generally you might think that older people are less connected with technology, but that doesn't mean to say all old people. And that was one suggestion when we presented to Public Health England, that they might extend Every Mind Matters for older adults. And I feel I see that now when I look at Every Mind Matters. There are pictures of older people on the website.
Yeah, great. Thanks, Ruth. And Rachel, I wonder if we sort of look at some of the, start to think about some of the broader issues, the broader context of this campaign, other like Time to Change, other campaigns as well. I mean, are we at risk of leaving behind anyone in these campaigns, and how might we avoid leaving people behind when we develop these and roll them out?
Yeah, I think we are, and I think it's the kind of the same people who are always left behind, right? Like the people who have more severe or long-term difficulties, and people whose difficulties relate to political realities. people who are subject to the hostile environment of the DWP or the Home Office, or like you can't meditate your way out of that. And I understand that and I'm not saying that people with more severe difficulties that we interviewed, like a lot of them found some really useful stuff in this. So I'm not saying that like it's no use for those groups at all. But just that if we don't acknowledge that this is aimed at a specific demographic, like in Karen's slides that you shared, it was very clear that it was an early intervention thing and that it was aimed at people who, you know, maybe didn't have diagnosable difficulties at that stage. And that's fine, but then don't call it Every Mind Matters, because if it's a public health campaign, the whole public sees it, and that includes the people whose difficulties aren't referenced. And actually, particularly during COVID, if you're like, people experience like really difficult exclusion from services that are supposed to support them. And it can then, I think the impression that I got from the people that we interviewed, it can then feel like, oh, this isn't for me either. Like the services that they're signposting me to, they're not for me. And like, even the website isn't for me. And that can kind of like, that's, you know, the stuff that Ruth explained about the context that we live in. I think we have to acknowledge those in these kinds of campaigns. And I don't think that that necessarily means that it has to be a completely different campaign. You know, I think there's some work that we did on a different project, but I'll get around to how it's relevant, I promise, on mental health and loneliness. And we wanted to pull out like some of the things that people had found helpful without it being a kind of have you tried mindfulness type situation. And the way that we did that was by making it clear that we were people who had relevant lived experiences, and that, you know, sometimes we try something ourselves and it doesn't work, and then we try it at a different time and it does. And like really being upfront with like, take what is useful to you from this and feel free to leave the rest. So I think that for me is the way that I don't know that it means that we can do it without leaving anybody behind, because the scale of a campaign like this, I don't know that that's possible. But I think that it can at least kind of give a name to the risk of exclusion. And that I think makes quite a big difference to people actually.
Great. Thank you. Thanks very much. That was really helpful actually. Yeah. Yes. Yeah. I mean, it's the likelihood that we can't, there will always be some people, whatever we do, there's people going to be left behind, whatever. So it's just mitigating it, sort of, and making that as acceptable as we can. So, Karen, I wonder if you could come in, and thanks so much for joining us with all the technical issues. And we introduced you earlier in your absence. So I wonder, could you give us some thoughts about where this goes next? I mean, what extra work do you think would need to be done to develop, you know, the website maybe specifically, but maybe the whole program? You know, where does this go? And would you have done things differently? What's the future for this sort of campaign?
Yes, thanks. And I had intended to be with you today, but come back from a lovely holiday, not feeling great. Yes, I mean, I think, as I hoped, I was trying to make clear in the slides, is that the campaign has actually evolved a lot from its original inception. And I think the COVID pandemic was responsible in large part for that. So I think we did move away from having literacy as a very overt focus to a point where really it's been about generating action. So, you know, thinking of the Kutcher definition of literacy, it's probably more of a focus on point one. And what I am pleased about is that what we have done since launch is we've expanded expanded the number of services that are available via the website, and we're getting some great results through now in terms of people reporting better mental health at the start than they did at the beginning. So, for example, we've got a new anxiety email program. We've obviously got the email program that can be done post the Mind Plan as well. But we've got 4 out of 5 people doing those programs now saying they feel better as a result. So I think in terms of where it goes, it's about for us, it's about producing more results that have a demonstrable impact. That the people who are using them are saying, yes, this has helped my particular problem. That's what we're looking to do. I mean, there's always more we can do. Budget is obviously, or lack of, is our major stumbling block. I listened very carefully to the conversation that was had just then, and if we were in a position to be able to do more and bring in a wider group, we would. What I would say is that there are plans afoot across government in terms of potentially making Every Mind Matters part of a bigger mental health. Well, it's obviously part of mental health ecosystem anyway, but make it part of a bigger digital mental health ecosystem that will enable a wider range of people with a wider range of needs to access additional sets of resources. So, the sort of resources that now might only be accessible following a primary care pathway will be made directly available. That's the sort of intervention that's being looked at. So, Every Mind Matters will hopefully continue to sit very much in a sort of preventative or enabling people to act on early signs of mental distress, but it will be part of an offer which enables easy access to a wider range of services. I mean, obviously, for people with more acute and specialist problems, it's very difficult, it's more difficult to sort of to reach out to them in the way that we do with Every Mind Matters at the moment, because their needs are more specialised. As I say, we're dealing much higher up the funnel. And I think it's going to be very difficult for any digital product to cover off the range of needs in a way that indicates that this is a comprehensive and fully appropriate response. I mean, I think some of the people facing some of the more acute conditions, they're always going to need specialist help. A website alone is not going to be the answer. But I think it's having an expanded web offer that sits as part of a more integrated sort of ecosystem that will hopefully demonstrate that every mind does matter, and ensure that there's a wider range of services available to meet the needs of a more diverse group. So that's the direction we're heading in. But of course, we don't have control over budgets. We potentially have a new government coming in next year, so we don't know where we'll stand. But I think at the moment we are getting some encouraging results through. So even if the literacy dial isn't moving massively, we are getting data that shows that by using our resources, people are reporting a positive impact on their mental health.
Great, thanks, Karen. I guess following on from that, and question for the whole panel, how do we keep such initiatives high up the policy agenda, the research agenda? And because I don't know where we would place it at the moment on the research and policy agenda. I mean, it's, to me, as my background is economics, and it seems, I mean, not just in mental health, but other areas of health, prevention and promotion is so important. And trying to address things occurring at a very early stage is so important. And yet, certainly within research, so much of the research funding is for addressing problems once they have developed and have occurred. How do we do that? Does anyone have thoughts on how we can be advocating for this more?
I can tell you what we're doing at the moment. It's about playing into the economic agenda, because we know that mental health is the second largest cause of people being unable to work after musculoskeletal problems. So it's very much what we're doing to try and keep it at the forefront of ministers' minds is showing that how it can have a positive impact on people's mental well-being, and therefore people who are struggling to stay in work because of mental health difficulties, if it's made available to them, hopefully it can actually help. It's now been embedded in DWPs. I heard them being mentioned in not most complimentary tones a while ago. It's now been embedded as one of the interventions as part of their midlife MOT. So I think it's, so I think the wider importance of mental health and the impact of good or bad mental health on the economy is being recognised. So I'm not saying that's the ideal way in, but it's certainly, you know, the way we're looking at Every Mind Matters at the moment in terms of the positive impact it can have of helping people at an individual level, but also hopefully helping you know, helping to address wider economic issues, given that the shockingly high number of people who are unable to work at the moment because of mental health problems. You know, it's obviously not the only solution there. Other interventions are needed too. But you know, that's one way in terms of getting politicians' ears, because you know the growth agenda is very much top of mind at the moment. You know, how we can recover from you know the pandemic and you know the general economic crisis, and helping to address people's mental health difficulties is one way of doing that.
Anyone other thoughts from the panel?
I have some thoughts.
Yep.
as usual. I guess I want to turn the question round a little bit,
Yeah.
if that's okay.
Please do.
Slightly apprehensive,
No.
but also not entirely surprised. I think that actually the research agenda needs to focus, if we're looking at prevention and early intervention, really on the social determinants that are involved there, like and I think, yeah, we need to be looking at like, how do we alleviate poverty? How do we try and reduce some of the harms caused by racism? Or like, and those are huge questions, and it's not popular necessarily to say that that's what needs to happen in the research and policy space, because it's hard and it requires people to acknowledge that those problems are there, which not everybody wants to do. And it's not necessarily easy to map those onto campaigns when those campaigns are funded from the government, and I understand that, but I think otherwise it's going to be very difficult to create measurable change, really. Like, yeah, I don't see any other way around it, to be honest.
So going much further downstream and sort of looking at some of the economic precursors to situations.
Just just acknowledging those in a prevention campaign, like validating that people, like, it's not insane to be stressed at work. We don't live in we're going through a massive economic crisis, like, and that there are ways to manage that, but like not like validating the kind of really difficult situations that people are in, I think can be something that stops those just blowing out of control and becoming a full-blown crisis, you know.
Yeah.
I wouldn't disagree with that, but that is a massive elephant to eat. And I'm not saying we shouldn't start nibbling away, but that's about whole system intervention. And interestingly, we've been talking to the Singaporean government recently, because that's something that's very much top of their mind. And the way they're looking at it is actually interventions on a local level. So, you know, it's actions that local councils over there, you know, can take that are going to address those drivers. And whether that's, you know, that's a model, you know, something that we could do here. And I think there are some areas that will be looking at that, but, you know, it's an absolutely massive issue. So in terms of, you know, what we're doing, trying to report against those macro factors, which are outside the control of the Department of Health, it's a bit of a non-starter. But that's not to say there isn't a role of having that conversation with, you know, other parts of government that you know, do have levers that they can bring to bear. But, you know, we just have to, you know, think about, you know, what we can do, what we can have an impact on with this particular intervention. But, you know, I'm not denying there isn't a wider role, and it is one that's being looked at in some quarters. But, you know, we can talk to the Singaporean government, but say ultimately, you know, we don't have authority over housing, over all the other factors that are driving poor mental health amongst our population.
No, I absolutely. I guess I was just thinking that it's possible to acknowledge in a campaign that those are drivers of people's poor mental health, without having control over them, you know.
It is acknowledged in our planning. It's just not anything we can measure activity against, unfortunately.
I mean, maybe that's where, you know, the sort of the research academic community needs to be taking lots of initiative and sort of developing that whole research base, isn't it, and feeding that through, because it is long term, isn't it? It's going to be a long term approach, and if we're not providing the evidence on that, then it's not going to
Yeah.
be picked up on, is it?
And it's not just mental health, it's a lot of other, it's back to the Marmot review, isn't it? I mean,
Yeah, well, I
has to
think
be-
it's inequalities, isn't it? And
Yeah.
disparities, yeah. Yeah. Any questions from the audience or online? Yeah, question at the back.
Hello, yes, thank you. So my question is about well-being at work, mental health and well-being at work. That was mentioned specifically, and I wonder what kind of integration could be possible with the occupational health services, occupational health medicine and nursing, and the campaigns like Every Mind Matters, because of course mental health is a huge part of occupational health. Could there be any synergy, any multidisciplinary teams formed, or processes could take shape for these professionals to work together, professionals that are part of the campaign and the medical specialty? Thank you.
Thank you. Who would like to?
I'm hoping Karen will say.
You got any thoughts on that, Karen?
Yeah, no, absolutely. So certainly at the level of Every Mind Matters, we do promote it to employers. We do encourage them to come on board as partners, and we've had a whole range supporting us in the past. You know, we're very happy to disaggregate our resources if they're interested in particular ones. You know, if they've got, you know, shift workers who need help with their sleep, we had conversation with a particular, you know, large employer and company serving the public to look at potentially doing that. You know, they can embed tools like the Mind Plan, but then on a wider level, there is work going on across government, led by our friends at DWP again, because there are all sorts of issues that need to be looked at, you know, around statutory sick pay and the like. But that is all on the cards. So, but as I say, it's a DWP lead. But I absolutely agree that, you know, there needs to be a sort of stronger interface between occupational health and other interventions to support mental well-being. And it is on the cards. It's just yet another big one to crack. But I absolutely agree with the person who asked the question.
Any other panel, any other thoughts on that? I mean, something I would want to follow up on with that is, I agree with you, Karen, the point you were making earlier about how often the routine is to convince governments that, you know, people get back into work, and so approaches like this could pay for themselves. And I guess IAPT was like that as well, wasn't it? It was,
yeah,
you know, Richard Layard, economist across the road at LSE, saying, you know, people come off benefits. But one thing that's always made me two things that made me uneasy about that. One is that it's, you know, work can cause a lot of the problems in the first place, can't it? I mean, I was talking to somebody yesterday, a psychologist who I met somewhere socially, and, you know, talking about, you know, how people can get signed off work, they improve, their health improves, they go back to work and it deteriorates again. So it's the nature of work can be a big factor in some of this content. And also, you know, is it people being occupied with their time rather than working with their time, which is slightly different, isn't it? It's, you know, how are we, because, you know, maybe it's, you know, quite a way off, but the more the automation takes hold, you know, the sort of the link between income and work is going to weaken anyway, isn't it? And we're going to have to think about the whole work life, work leisure relationship, aren't we? Sorry, I'm mumbling a little bit, but I guess it's, you know, the aim of if somebody is experiencing depression, you know, the aim is for the symptoms of depression to reduce, and if by that happening someone gets back into work, that's good. But even if they don't get back into work, if the depression has gone down, then that's a good thing, isn't it? I don't know.
Yeah, I have to say the best thing I've ever done for my mental health at work was join a union. So make of that what you will. And having recently resigned from a job because of the impact it was having on my mental health, I think yeah, there's a lot of complexity in that.
Yeah. Okay.
Yes, I mean, overall, we know that, meaningful work is good for people's mental health, but, not everyone is in that fortunate position. So again, I think it does come back to, and there are initiatives in place to, encourage employers to appreciate and do something about, the value of fostering good mental health amongst their employees. But we're not there yet. I mean, stigma is another thing. I don't think anyone worries about, going to their employer saying, I've broken my leg, I can't come in. I've got severe mental health problems. That's another issue, and we're not there yet either. So it's about having appropriate policies in place at company level, but I think it's also about breaking down the stigma, so people are quite happy to say I'm suffering from low mood in the same way as they would, like I did this, by me saying I had a mental health problem, but the same way I just said, look, I think I've got a very nasty cold coming on. I'm not going to come into the office. Nobody bats an eyelid.
We've got a question on the chat somewhere. Do you want to read it out?
Yeah, that's absolutely okay. So Sarah, who's joined us online, has posted a question, firstly saying, I do worry about those like myself who have the level of mental health distress where it doesn't fit neatly into the boxes that these public health campaigns are aimed at. How do we get beyond entry-level mental health distress and towards those who often can't be supported by the limitations of IAPT and other low-level approaches to mental health support? Campaigns are great, but often barely scratch the surface to meet needs beyond hard-to-measure awareness and understanding.
Great question. So.
I completely agree, but I don't think it's the role of campaigns. I think it sounds like there are some particular challenging issues here, and it's got to be a question of working with primary, possibly secondary care as well. A campaign would not be right for addressing some very acute specialist problems.
I mean, sorry, I didn't mean to interrupt.
No, that's fine. I mean, to be honest, we're in a bit of a numbers game. It's looking at the people who are, the mass of people experience low-level mental health problems on a regular basis, but only up to a certain level. Once you get, and I hope that Every Mind Matters is very clear where it can't help people and where people shouldn't see it as being the be-all and end-all, and the solution to their problems. I hope we do a good job of actually encouraging people to go to their GP or potentially just to self-refer to IAP. But I see that very much as just the start of the journey. But I really don't think that's the role of a campaign for people who've got very diverse acute problems.
Yeah.
I mean, I guess I agree that's not the role of the campaign, but I'm not sure that's, I think what we found, maybe Ruth will have a different take on it, but I think what we found in our qualitative study is that regardless of who the intended audience is, people with severe mental health difficulties are still getting this popping up on their Twitter algorithm, or seeing it. You don't control who sees it. If it's a public health campaign, everyone in the public is part of the audience. And if you only measure the impact on the people who you want to see it, then you're not measuring the whole impact. So I think
I understand that, but it's about measuring what it does seek to do. But I think you raised an important issue, and that's one of the reasons why the sort of a wider sort of digital solution is being looked at the moment. But it is going to be it is very difficult. That's not to say we shouldn't look at ways of solving the problem, to be able to address the needs of the full. I think I probably had a chart in my deck that went from people who are flourishing to people who've got really very serious problems. It's I'd say nigh on impossible for really one campaign to be able to meet the needs of all the people right across that spectrum. And yes, you're absolutely right. Although we do try to target as finely as possible, there will be over here amongst people who shouldn't be in our core target audience. And to be honest, currently even the most refined media planning can't tackle that at the moment, and we don't want to waste our money, so we do try to target as tightly as possible. But there will be that over here, and I think certainly in the short term it will be about, which is something we are looking at, adding additional signposting for Every Mind Matters. But ultimately, at the end of the day, it is going to have to be about going to primary care for people who are in that very difficult situation, and off the peg solutions just aren't working for them.
Yeah, no, absolutely. I guess the difficulty is then that if that what we found when we spoke to people is that if then the places that people are signposted to can't keep up, which is what is happening to people, that can kind of really compound some kind of difficult experiences of exclusion. And I'm not I'm not saying that Every Mind Matters should actually be able to cater for everybody, but I guess the question that we got and the results that we've found maybe just suggest that think going forward it would be quite useful to kind of acknowledge more the people who do need more, and also acknowledge that those people maybe can't find it elsewhere.
Several times during this study, I kept looking at Every Mind Matters website and the NHS website generally, and thinking that physical health web pages address health problems at different levels of severity, and couldn't that be the future of Every Mind Matters? That perhaps that's what Karen's suggesting, that it just does expand to not necessarily be a campaign, but be this massive resource.
Part of the ecosystem of
Yeah, and that is what we're looking at. I'm working with the NHS at the moment on looking at how that might be, and and there are some great resources locally as well. So it's how we might bring together in a more user-friendly way the great range of resources that are available to meet a wider range of needs. But I think I have to go back to at the point in time when Every Mind Matters was conceived, it was there to do a particular job. But I think in starting to do that job, it just reinforces the wider job that still needs to be done. And we come back to our friends or enemies, time and money, but it is something that's well, it's more than under consideration. I mean, just look at what was, look at the spring statement. A lot of money is going into developing digital mental health solutions.
Brilliant. So any final questions from the floor or online? Yeah, it's a question there. To be a fairly quick one and quick answers, because I know Rachel's definitely got to go to another panel.
Oh, fine. It was quite specific to start with, so maybe I'll just say that about just wondering, the measure you've developed, John, sounds really interesting to move away from basically knowledge of a diagnostic category to actual kind of useful knowledge. But I wondered, without that framework, how you selected the items, especially the kind of useful actions.
Well, we kind of really just had a very quick review of the existing literature out there, and looking also partly into the content of Every Mind Matters as well. So we thought to achieve the best alignment, kind of to focus on those actions that are covered, mostly covered by Every Mind Matters as well. And we checked against the literature as well, that there are certain level of evidence behind each of these recommendations. So that was how we kind of develop our focus. And we also ran it through with the lived experience working group of EMPRO, as well as and I think there is another academic another panel of academic expertise in EMPRO also. So we ran it through 2 panels after kind of proposing that kind of focus. Yeah.
Just one other quick point to add as well is we do keep our eyes all the time on what people are looking at on Google, so we can see where the public is at in terms of what it's looking for, and it's in terms of looking after its mental health. That obviously then needs to be mapped against the scientific evidence, but that's something that increasingly we are doing to make sure that we are meeting current needs.
Great. Okay, we've got one final question or point online.
Oh, hi. Can you hear me? Can you see me? Hi.
Yeah, over to you. Yeah.
Hi, Taryn Jackal here. Quick question, more on the hypothetical. First, I should preface that I am a former civil servant and asking from this point of view, Karen would know too well. I'm a current MSc student on Every Mind Matters, so I can ask this because it's amazing in some respects that with the budget that EMM had, it has achieved what it has done. But reality is, we all know that there's a parity of esteem issue in mental health and physical health. Say tomorrow, hypothetically, the budget was doubled. Where do we think the money should be spent in terms of reaching as much of the population as could be reached? It's a question for the whole panel, really.
Gosh, who wants to challenge that in 1 minute? Where would you spend that doubled budget?
Multilingual content. There we go.
Multilingual content, yep.
A map of local resources,
What's it?
a map of local resources
yeah.
that cater to social determinants.
Chong and Roo. Roo.
I'm stumped with the idea of having double the resources.
Karen, where would you spend?
Oh, I know straight away, because the budget hasn't actually been cut this year. I'd spend it on resources for young people specifically, because much of what we looked at there is aimed at adults, and we all know how young problems start. So I'd go back to having a more beefed up problem. Tan, you'll remember Rise Above that we had years ago at PHE. I'd go back to producing something like that. So being able to beef up our communications direct to young people and to the work we do in schools as well, supporting the RSHE curriculum, that's all had to fall by the wayside very largely due to budget cuts. So that's where I put it in. So absolutely in prevention, starting young.
Great. Excellent. That's a good note to finish on. And I'd like to thank everyone who's joined online, everyone who's here physically. I'd like to thank the panel. I'd like to thank you, Karen, for joining with all the technical issues. And thanks to our wonderful tech support as well, who've done amazingly with the difficulties we've had. So thank you. Thank you, everyone.